So thank you very much, Professor Tudor, to be here with us in this interview to LINNC online. So, Professor, first of all, after the recent MeVO trials, do you think that we have to search some alternative strategies to explore this new field, or this field that we saw not very good results in the last trials?
Yeah, well, thank you for having me. It's a pleasure to be here in São Paulo for the first time. Great attendance, great discussions. Great to see how many interventional, how well developed the field of neurointerventions is in Brazil. And to the question of whether we should do something about the MeVO trials and patients who have acute stroke due to medium vessel occlusions or distal vessel occlusions, the answer for me is an emphatic yes, because one thing that emerged from these trials is that the outcomes are not that great. Okay, so they're not as bad as more proximal vessel occlusions, but not that much better in non-treated patients, in the control groups, right? So clearly, we need to devise treatment, whether they're going to be endovascular or not, that should improve outcomes in these patients, right? So,
and do you think that we need more trials to maybe analyze if there are some subgroups that will benefit from the MeVO treatment?
Right. So I think that the fundamental level, we need to think about whether the answer is endovascular, whether the answer is reperfusion, intravenous, whether the answer is in a combination of these factors, and whether there's any other approaches, such as neuroprotection, for instance, that could to get us to better outcomes. So on the endovascular side, okay, I personally feel that we were a bit greedy, okay, in our approach. We were accustomed to these huge treatment effects, very large treatment effects that we saw in the proximal large vessel occlusion trials. And we thought that we can keep going like that with very few patients, very broad inclusion criteria. And, to me, one of the lessons that I learned from the thrombectomy trials is that the most important factor that determines treatment effect, benefit from treatment, is the severity of the deficit, right? So I think it's been a bit, nothing, no criticism to our colleagues from Canada, the Calgary group and the group from Bern that have done the respective two trials, and the one from France. They've designed great trials, and I think, it has advanced the field, and we can build on what these investigators have accomplished. But to me, one lesson that I took from all the thrombectomy trials before the MeVO trials is that the severity of the neurological deficit is the most important factor driving treatment effect, okay? Not prognosis too, but also treatment effect. And we've seen, whether it's the anterior circulation or the posterior circulation, that mild strokes, mild deficit, low NIH stroke scale scores on presentation tend to benefit less, which is completely logical, right? From thrombectomy. So I'm not surprised that, once we include these low NIH stroke scale score patients, who do have, by definition, a smaller area at risk. The stroke severity versus total area at risk is, the ratio is much lower than
Alveolar.
than proximal large vessel occlusion. I'm not surprised that we didn't find benefit. So I think we need to refine the inclusion criteria, refine the patient selection. I would start by, putting a limit on the NIH stroke scale score, maybe 6, maybe 8, to maximize the benefit of reperfusion in terms of salvaging tissue at risk, right? So, I mean, that to me is a low-hanging fruit. The other problem with these trials, in my opinion, it's easy to say that in retrospect, but, is that, all these, every vessel occlusion was lumped together, right? A PCA, an ACA, an M3.
Yeah, completely different.
And probably the outcomes should not be the same based, in all these vessel occlusions. So a PCA, for instance, it depends. If it's more distal, the main deficit is gonna be a visual field defect for which a ranking score is not the most adequate endpoint, right? So we need to tailor the endpoints to the kind of deficit and disability that we expect we're going to get. And the ranking score is probably not granular enough, not good enough, discriminatory enough. It's good enough for this large vessel proximal occlusion. The territory at risk is very large. And, the ranking score with all its limitations is a good endpoint. But for the more distal vessel occlusions, probably we need to refine the endpoints. The other factor is that we know that the smaller the vessel, the better the response to intravenous lytic drugs. So it's possible that at some point, for a certain vessel size, intravenous is better than thrombectomy. It's possible that we're reaching the size of the vessel, the limit in terms of the size of the vessel, where thrombectomy may be beneficial. Fourth, the tools that were used in these trials for these smaller vessels were designed for larger vessels. So that's also something that needs to be adapted. We need to get devices. It is a bit of a, if you want an analogy with the 2015 versus the 2013 generation of trials, where you had inadequate reperfusion devices in IMS3 and MR rescue and so on and so forth. And then you had much more effective reperfusion devices, and that was the main difference why the earlier trials were negative. It's possible that there's going to be a need for improvement in devices. But again, regardless how good the devices are, we don't even know for sure. There's randomized trials now in progress that look at low NIH stroke scale score, even in large vessel occlusion, right? So if the low NIH stroke scale score, if thrombectomy for low NIH stroke scale score in proximal large vessel occlusion is not beneficial, how can we expect it's going to be beneficial in more distal occlusion? So I would start with, the first thing I would do is I would separate the vessel occlusions and then start with more severe deficits. There is a bit of a question whether early versus late, do we have the same time window as in proximal large vessel occlusion, as in M1s or ICAs or basilar? Maybe the time window is not as expansive as in proximal large vessel occlusion. So that's also something we need to look into. And then lytics. I think lytics, whether intravenous or intraarterial, and there are other lytics other than TPA and TNK. They're probably better and probably better suited. Because of thrombectomy, we just completely have stopped developing lytics. So that's another approach that I think has to be also part of the conversation.
Yeah, of course. And Professor, maybe with the discount trial, distal trial, and the escape MeVO trial, we are the same stage as the 2013 for the LVO. So maybe we are learning how to better select the patients and then maybe have better evidence. And how do you think that our community should adapt our strategy to with this new evidence from MeVO treatable? Do you think that you need to select the patients, each one, if though this MeVO I can treat, maybe there's a better benefit to the patients or not? We are not treating anymore any MeVO.
Yeah, so I mean, look, I think that as opposed to, I see the analogy, but on the other hand, these are patients that we weren't treating, or we weren't treating until very recently, these MeVOs. And as opposed to the large proximal large vessel occlusions, everybody who were treating these patients, the clinicians, I mean, I was, as I used to call it, I was in illegality, right? Before the 2015 trials. I mean, I was convinced that it works, right? Because you would see those, immediate, benefit. Here, I think there's true equipoise. A lot of us are not convinced of the benefits. So from that standpoint, I think it's a bit of a different situation, and that's good because there is equipoise, and the answer is going to be through trials. We need to do more trials. We need to reset the inclusion criteria. We need to select patients better, and test different approaches, not only thrombectomy, but thrombectomy with perhaps different devices compared to intraarterial lytics. I mean, intraarterial lytics now have made a big comeback, right? We know all these trials post thrombectomy, and in a certain way, this proximal vessel occlusion, distal vessel occlusion situation could be analogous to the distal microcirculation thrombi situation, and maybe lytics, intraarterial or intravenous, are the answer. So we need to test all these approaches. One thing is clear: the natural history is not that good. So we need to, we can't give up on this condition, and we need to test new approaches. And I think there's the equipoise has been reset. I think most of us really are on the fence whether these approaches work in MeVOs. I'm not talking about proximal, dominant M2s.
So it's
okay. I think that's probably going to be a tougher sell in terms of participating in trials. Even though you could make an argument for including those as well, but probably that ship has sailed. But the answer is more trials, and I hope there's going to be trials in Brazil and or participation from Brazil, because you guys have so many patients and such a great infrastructure here, to help us answer this question.
Professor, thank you very much for your interview and for all your efforts to improve the mechanical thrombectomy and treatment for stroke in our field. Thank you very much.
Thank you. My pleasure.